Good afternoon. Thank you for joining us. My name is Christian Hunter, and I'm here with Dr. Christopher Farnsworth, who's Associate Professor of Medicine of Pathology at Washington University. He heads the clinical chemistry section there, and importantly to us, he is the co-director of the fellowship program. He's going to be talking to us today about natriuretic peptides across the spectrum of heart failure, but in addition to that, be talking about some other biomarkers of interest and multiple disease states, and we're very, very pleased to have him here today. Chris, thanks for being here.
Yeah, thank you very much, Christian. It's my pleasure. I'm very excited to chat about this topic with you all for the next few moments. There's the speaker disclaimer and the title for today's talk. I do have the following conflicts of interest, including research funding from Abbott, as well as advisory board work for Abbott. So at the end of this next 20 minutes or so, I want you to be able to explain the primary applications for natriuretic peptides and troponin, particularly as we think about it in terms of diabetes and cardiometabolic disease, evaluate the emerging uses of cardiac biomarkers for this purpose, and recognize some key limitations and gaps in the literature. So we're going to start just with a simple definition of cardiovascular disease and how it's the main cause of mortality in the United States. Almost a little shy of 1 million people, 702,000 people in 2022 died from cardiovascular disease in the US alone, which is about 20% of all deaths in the US. And it's primarily due to myocardial infarction, heart failure, and arrhythmia, with the risk factors being mostly diabetes, obesity, inactivity, and excessive alcohol use. And you can see in the scattergram on the US plot here, red being bad, we're right in the middle of the red this week. So hopefully you found some time to get out and exercise, maybe go on the Univance run with Trisha. So cardiovascular disease and cardiovascular-kidney-metabolic disease syndrome is starting to be more and more well recognized in the field. In fact, this is a definition that's just started to emerge in the last few years, at least in guidelines. And really what it's doing is it's emphasizing the risk factors and links between kidney disease, cardiovascular disease, and metabolic disease, such as in diabetes. So obesity, high blood pressure, high cholesterol, high glucose, and really kidney disease driving them. So throughout the talk, I'm going to use the phrase CKM syndrome, which is really referring to the constellation of these three diseases. And this is kind of a busy slide, so the take-home is not really to get anything from this other than to understand that there's a unique interplay between having excess adiposity, metabolic disease associated with it, and type 2 diabetes, how that partially drives renal disease, how it's also going to drive cardiovascular disease, and how that renal disease is then going to go on to drive cardiovascular disease. So we kind of get this vicious cycle of one really driving the other forward. So for patients, this is really bad news because you get one of the three, it's going to potentially drive the other two, particularly if you start with obesity and type 2 diabetes. So actually what we're starting to see is staging systems that have come out that look at trying to look at patients with CKM syndrome. So again, you've got your very healthy runner on the left with no disease. As we move into stage 1, you can see here this is mostly just excess adipose tissue. Moving into stage 2, now we've got metabolic disease. So we've moved on from excess adipose tissue to, for example, type 2 diabetes or prediabetes, and you really start to drive the initial stages of some of these syndromes, for example, early stage kidney disease and hyperfiltration. That then moves into the subclinical disease, which we're going to talk almost about the entire talk, but you can see here it's atherosclerotic disease and heart failure. And then we can finally move into the fully symptomatic phase where patients have full-blown renal failure, full-blown heart failure, and overt type 2 diabetes. What's really interesting, and again, the text is a little small here, but this staging that we're doing for cardiovascular disease in the subclinical space is going to be patients without symptoms primarily. So we're using mostly biomarkers in these patients to try to diagnose this specific disease of CKM syndrome, or really more appropriately a syndrome. So this was a nice statement that came out from the AHA just within the last couple of years, trying to really define and get at what is CKM syndrome and how can we help treat these patients. And what they did is they diagnosed this subclinical heart failure using elevated cardiac biomarkers with an NT-proBNP greater than 125, a troponin T greater than 14 or 22 in females and males, or an I greater than 10 or 12 in females and males, which is a really unique statement to have these very specific biomarker thresholds for a syndrome that's brand new. So we're going to talk about these biomarkers, where these thresholds came from, and maybe talk a little bit about what we can do next as a field to try to improve on treatment of these patients. I want to also point out this is not just the AHA that has this. This is a slightly different staging system, but this is looking at the American Diabetes Association. And they have very similar, they have different stages, but you can see for stage B, structural disorder without symptoms, increased filling pressures, or elevated biomarkers. They use actually different thresholds, which is in and of itself a very interesting conversation to have, but by and large, very similar consensus among different organizations. So let's talk about these two different biomarkers for just a minute. First, natriuretic peptides. So natriuretic peptides are released from the heart in response to cardiomyocyte stretch as pro-BNP. They're then going to be cleaved at the 76th amino acid to make the biologically active BNP, which is going to cause diuresis and downterm stretch, help you get rid of that excess fluid, and NT-proBNP, which doesn't actually have any biologic function that we currently know about. So you can see here where they're cleaved and that they're produced in a 1-to-1 molar ratio. And the hallmark studies for BNP and NT-pro are both shown here. They've been used as biomarkers for almost over 20 years now, I believe. You can see the breathing not properly, or BNP study on the left, very clever, looking at patients with acute heart failure. You can see in gray that those that had acute heart failure had much higher BNP relative to those without. And on the figure on the right is looking at the similar original study in NT-proBNP, demonstrating its utility for acute heart failure, showing that it's, again, much higher in patients that have acute heart failure as clinically adjudicated versus those that did not. You can see that they have very similar sensitivities and specificities in these studies. Now, a question, and if you noticed on that last slide, actually the thresholds for acute heart failure are quite high. They get up as high as almost 2,000 in certain subsets of patients for ruling in heart failure. But the thresholds that we're using clinically, particularly when we're thinking about patients with type 2 diabetes in an outpatient setting, they're going to be quite a bit different. As I mentioned, 125 is what folks are generally using. So where are those coming from? This is going to start to get at some of those thresholds. These are actually thresholds that are recommended from the European Society for Cardiology, which are shown here for both BNP and NT-pro in the ambulatory space, as well as in the hospitalized decompensated group like I just showed. So you can see they're quite a bit lower. I'll also point out that the reference intervals are even lower still. So if we look at the reference interval, for example, for NT-proBNP, it's around 64 for males and 95 for females. And what's really interesting, this is a study that was published just a couple of years ago looking at, I think, about 18,000 patients, so huge study, looking at what are the concentrations of NT-proBNP in a healthy population, so people without metabolic disease. They're actually quite high. A lot of them are quite higher than even the thresholds we're using for ambulatory patients. You can see the females in particular, postmenopausally, it is not uncommon for them to be above 125, with about 30% of the population from 60 to 69 living above that range. And even for males, as they get past 60, it starts to increase. But a large number of patients live above these thresholds that we're using in the non-acute setting for ruling in heart failure. So another question that one could ask is, how well do these assays correlate? This is a study that we published back in 2017, 2018, where we measured serial samples on patients with BNP and NT-proBNP. So we had a specimen drawn for each assay at the same time, and we tested them on each assay for all patients with suspected heart failure coming to our hospital for 2 months. And you can see that while they don't look great on a linear scale, if you look on a log-log scale, they actually correlate quite well with a Spearman correlation of 0.7. And really where we're interested is down in the clinical decision limits, particularly if we're thinking about acute heart failure, rule in and rule out. And really the take home here is that while these assays are not interchangeable, they give different concentrations depending on the assay that you use. By and large, clinically, they're fairly concordant. They're going to use different cutoffs, but we're going to rule in and rule out the same population very frequently, with 72% falling within guideline recommended thresholds in the rule in zone or rule out, and just a few proportion really being in the discordant area where we're saying one biomarker says rule this patient in, one says rule out. So less than 5%. So they actually perform fairly similarly. And now, actually, what's been really interesting is that for years, NT-proBNP has really only been offered by one manufacturer. And there are some things that make NT-pro a little bit easier to measure for laboratories relative to BNP. It's more stable. For example, BNP usually has to be drawn into an EDTA tube and processed fairly quickly and tested. NT-proBNP does not have those same limitations. So other manufacturers have started to come out with assays for NT-pro. So here's a study that we recently performed. And actually, this is not yet published data. This is currently under review. It's comparing on the left side results from the Roche NT-pro to the Alinity NT-pro assays. And you can see that the correlation is near perfect with a Deming regression slope of just about 1. I think it's 0.98. So they correlate near perfectly. And they also correlate quite well with the PathFast, which is a technically point-of-care box, but used more commonly, I think, in laboratories. With nice correlation, and you can see the inlays show that at low concentration, or high concentrations rather, they continue to be fairly linear. So the take home here is that the NT-pro assays that we have actually correlate very, very well and are almost commutable or perfectly harmonized across different assays. So how do we summarize this section? Well, natriuretic peptide elevation is due to cardiomyocyte stretch. And the definition of elevation may be dependent on a host of variables. For example, postmenopausal women start to experience a physiologic increase. There's an excellent agreement between NT-pro assays, and while there's a limited correlation between BNP and NT-pro, clinically they're quite similar in terms of how we're using them, both in the acute and non-acute settings. So the other cardiac biomarker that I want to just take a second to talk about is cardiac troponin. Which is generally associated with cardiac injury. So not stretch now, but some insult to the cardiac tissue. For example, in myocardial ischemia, you can't get blood flow to the heart, so you start to experience necrosis and the typical cardiac leak of troponin into the plasma. So the cardiac troponins are cardiac tissue specific. They have specific epitopes that are not shared with muscle, which is what is shown below. Everything that is in red are epitopes that are specific on the protein to cardiac troponin I or T. And everything then in purple is shared between the two. So if you're going to manufacture an assay, you really just need to target the epitopes in red, and you'll have a cardiac-specific assay. And what this is showing is just as a generalization, as we experience more cardiac injury, we can measure more troponin in that specific patient. What's been really neat with the release of high-sensitivity troponin assays is that we can now measure troponin in the vast majority of people that are even young and healthy. And this becomes relevant when we're looking at outpatients, particularly those with cardiometabolic disease, because we want to risk stratify them early using potential thresholds that would be lower than what we're using now to try to rule in patients for myocardial injury, like in the ED, for example. So while in this context, for myocardial injury, while on the right is what we're usually looking for, in the context of cardiometabolic disease in an outpatient setting, we're looking at much, much lower concentrations, which is where your accuracy and your precision really matter. Nonetheless, we have very specific criteria for myocardial injury, which is a detection of troponin above the 99th percentile upper reference limit. So this is from the 4th universal definition of MI, which is used, I think, fairly globally among almost every hospital that I know to try to rule in myocardial injury. And this is exclusive or includes both inpatient and outpatient settings. That is true. If you measure someone, if I were measured today and my troponin was a bit high, maybe you did the run on Monday and your troponin was perhaps a little elevated after if you don't exercise as much, then that would still be consistent with a myocardial injury. And then myocardial infarction is that injury, but the troponin is changing over time, plus acute ischemia. Now, where does that 99th come from? It's the universally endorsed cutoff. In fact, it should be male and female. The IFCC has been very specific about that. But it's interesting because most times in laboratory medicine, we're using a central 95th. In troponin world, we're using a 99th. Some of that is historical. We couldn't measure up to the 99th, or that was as best as we could measure up to. So we had to use the 99th. But it turns out the 99th is quite good at differentiating sick from non-sick populations. However, there are very specific recommendations from the IFCC as to how you should define your 99th. You need very large populations. You need at least 4 lots of reagent. You need to span ages. What I'll also point out is that while you probably don't need to read this plot, there's a lot of things that the IFCC is recommending that you do. For example, does your patient have normal EGFR? Do they have diabetes? Do they have elevated NT-proBNP? You'd actually rule all those patients out in your reference interval study when you're developing your reference interval. So as a result, as you measure different patient populations, that reference interval does change. So this was actually a universal sample bank, which was drawn at this meeting, I think 6 or 8 years ago. We took a whole bunch of healthy patients. This wasn't my study. This was led by Fred Apple. But they took those healthy patients. They applied the criteria from the previous slide. And what I'm sharing here is the manufacturer versus a universal sample bank for some of the common assays used on the market. And you can see that there is actually difference based on the population that you use. So for example, if we look at the Architect, 34 versus 20 for males and 16 versus 13 for females. But for some assays, it was actually higher using the universal sample bank, which is really interesting. I think the take home here is that reference interval is really going to be driven by the population you use to assess that reference interval. So your take home, troponin elevation due to myocardial injury, different from stretch, which is heart failure. Definition of elevation is really going to vary based on a host of different factors. For example, what is the patient presenting with? Are they younger or are they older? As well as what is your reference interval and how did you define that 99? So now that we've baselined there, let's take a few moments and go through this again with a bit more of a fine-tooth comb. So it says clinical heart failure is diagnosed by an NT-pro greater than 125, which is much lower than the acute thresholds, or a troponin I of 10 or 12, which is much lower than the reference interval. And I'll point out that this is assay agnostic. They don't say which assay. They just say this 10 or 12. I know where it comes from. I'll show you in a minute, but it's really interesting. So where do these thresholds actually come from? So this was a study that was published a few years back looking at 1,300 patients with cardiovascular disease risk factors. And they randomized them to standard of care versus screening based on their BNP. So in patients on the left, it's showing all patients that had a specific therapy, regardless of what their BNP was. And you can see that there's a little bit difference in terms of adverse cardiovascular events within a certain time frame. Here they're showing 8 years. A little bit better in the intervention group. But what they saw is when they screen these patients with BNP, you can actually increase, or when you find patients that are at higher risk and then you treat those patients, they actually do better relative to your control group. So this was one of the first data that showed that if we actually screen patients at high risk for BNP, we can potentially treat them and have a targeted group of patients that we're treating with specialist intervention, in this case, cardiologists. Similarly now, looking at NT-proBNP, this was the Pontiac study that was published a few years ago. I can't read my citation, sorry. I think it was around 2012, 2015. Anyways, they looked at 300 patients with type 2 diabetes, and they measured and they had to have NT-proBNP greater than 125. So that was actually an inclusion criteria in the study. You had to be above that threshold. And they basically took those patients and they randomized them and said that if you have one arm was the standard of care treatment, and then their intervention group was an up-titration of renin-angiotensin system antagonists and beta blockers. So really, are we going to give them standard of care, or are we going to give them more dedicated therapy? All based on patients with an NT-pro greater than 125. And what you can see here is that patients with the intensive therapy did actually have better outcomes, in this case, looking at cardiac disease over a span of 2 years. So this is, again, one of the early studies that showed that 125 might be a helpful threshold. Then what about troponin? Interestingly, there's not really a lot of data in the troponin world that necessarily supports the thresholds that we have specific to cardiovascular disease, but there are some good studies that have shown these thresholds being useful in the general patient population for risk stratification. So this was a pretty large study out of Norway looking at 9,000 healthy patients, and it was all samples were tested for cardiac troponin I, and they excluded anyone with known cardiovascular disease. So it didn't have patients in that cohort. So generally speaking, healthy patients. What I'm showing here, before I actually get into that, on this assay, this happened to be an Architect I believe that they used. The 99th percentile is 34 and 16. And what they did is they're then stratified these groups into 3 separate buckets, showing on your y-axis your survival probability, and on your x-axis is time in days. So this is quite a long study. This is one that you would not necessarily engage a fellow in. 6,000 days is too long to keep your fellow along, I'm told. But long postdoc, maybe.
Exactly.
But they bucketed these into the probability of survival. And you can see that patients that were very low, females less than 4 or males less than 6 in the blue line, did the best. In the middle are patients with females between 4 and 10 and males between 6 and 12 with their troponin I. And on the bottom, the orange, are females greater than 10 and males greater than 12. So those are the thresholds that are being used in these guidelines at the moment. And it's based, I think, on as best as I can tell, on this study showing that there is higher risk of mortality in patients that have a measurable troponin above 10 or 12 for females and males, but again, well below the 99th percentile, which makes the case that we need to have an assay down there that can measure that and can measure that reproducibly. So that is where those thresholds have come from. So that is what is currently being used. It's probably being used in your hospital now, and you might not know that your endocrinologists or perhaps some cardiovascular teams are using it. But there are still a lot of things that we need to figure out as a field, and where I think us as laboratorians can really start to dig in and really help. So there's limited clarity, and this actually comes a direct quote from that guideline. There's limited clarity on how to best target cardiac biomarker measurements in the population. The frequency of the testing, and appropriate next diagnostic steps, i.e. what should we do with them? Should we treat them with something? When we get these elevated biomarkers. So if we think about the problem more globally, I think 40 million people in the US have type 2 diabetes, with another much larger proportion having prediabetes. Who are we going to screen with NT-proBNP? We could test everybody, but that would be a huge economic feat to test all of those people. So who are we going to look for in that population to screen? And if we go back to those previous studies, it was relatively random. There was no specific thing where we're saying this patient has a specific set of features that we're going to pull them in. And that's what this guideline is really saying, is that we know we need to have something to know who to test. So what I'm going to show is a study we did next, trying to ask, are risk-based screening strategies effective? So what we did is we took 1,300 outpatients with physicians-ordered hemoglobin A1C, and we measured high-sensitivity cardiac troponin I on the Architect system in my research lab. And then we obtained the clinical data from the medical records. And what we found was that 59 or 8% of females had troponin I greater than 10, the threshold I showed previously, and 4.2% were above the sex-specific 99th. And if we look at males, 16% were above that 12 nanogram, and 4.1 above the sex-specific 99th. So remember, these aren't physician-ordered results. These are results that they're not thinking this patient might have some potential heart disease. It's things that we're looking for on a research basis. So they don't know that necessarily these patients have these elevated concentrations of troponin. So we then asked, what do these associate with? So there's a kind of a busy plot. I'll go through them fairly quickly. It associates really well with age. As you get older, troponin goes up. That's well known. BMI, not so much. EGFR, very highly associated, which is also well known. What we were really interested in was A1C. There's a modest correlation there. As patients had increasing A1C, their troponin I tended to increase, which does imply that perhaps we could screen patients above a certain A1C threshold and see if we could potentially use that as a surrogate for who would be a good candidate for measuring NT-pro. We also looked at previous cardiac history, and the only thing I'll pull out is that patients with heart failure and coronary artery disease had higher troponin I relative to those that did not have that documented, but still a large number in both groups that had elevated that were never previously diagnosed. So again, drilling in a little bit more on that A1C, what this is showing is as we go through those A1C buckets, low A1C, less than 5.7, between the pre-diabetic range of 5.7 to 6.4, diabetic range of 6.5 to slightly controlled at 8, and poorly controlled above 8, we do see a modest increase in troponin over time, but you can see it's not perfect. There's patients that have their full-blown diabetes with an A1C of 12 that have perfectly normal troponins, and people that have low or well-controlled A1C that are below that specific threshold, or that are fairly low troponin. So it does help identify, but not in a particularly specific way. We also tried it in a mouse model, because we have some fun collaborators at WashU. And it actually turns out if you feed a mouse a high-fat diet, they do become obese and diabetic, very similar to the human phenotype. And this is showing the blood glucose concentration when you give them a glucose tolerance test. So you give them some glucose, and you can see their glucose spikes, and they clear it in a normal mouse in black, but in the white circles or squares, you can see that they don't clear that glucose, very similar to humans with diabetes. But if we measure their troponin in those high-fat fed mice, they do actually recapitulate what we see in humans, but they don't have things like renal disease. They're all the same age. So we've gotten rid of some of those variables. So we do actually think that this could be a potential way to help risk stratify. How well is our patient controlled for diabetes? Transitioning a little bit, how do we use these to monitor? So we don't know who we should be testing, but then once we test them, if they're high, how should we monitor it? This was a study that was published, I believe, by Januzzi a few years ago. And what they did here is they took 66 patients with type 2 diabetes, and they treated them with an SGLT2 inhibitor or placebo. What you can see here is the time point from 26, 52, and 104 weeks. In blue are the patients that got placebo, and in red were those that got the drug. And what we're looking at is the change in NT-pro on the left. And what you can see is that over time, the patients that received that drug actually had about the same NT-pro. It didn't change, which is interesting. But the patients that did not receive that drug in blue had an increase over time. So the NT-pro went up in those that were not treated, but it stayed the same in those that were treated. So this is the percent change. And actually similar results, perhaps a little bit better, were seen with troponin, where they saw a slight increase in the placebo group, but in the treatment group, they actually saw the troponin concentrations go down. So this is probably some of the best evidence we have that cardiac markers aren't just helpful for assessing if someone has some clinical heart failure, but also assessing their response to treatment. But again, the frequency with which we test them and what are relevant changes in that biomarker is not yet particularly well known. And then I'll end with, I believe this study is my last one. This is another study that looked at serial monitoring in a little over 5,000 patients. This was published by Peter Gerolin. And what they did is they took patients with type 2 diabetes, and they had an acute coronary syndrome event within 15 to 90 days previously. And they tested all these patients at baseline and again at 6 months after that event. And what they did was ask if their NT-pro is changing, what is the probability of these 4 events shown on the bottom? So what you can see is that patients that had a low NT-pro that stayed low in green had a lower risk than those that started high and stayed low, which was a little bit lower still than those that started low with NT-pro and went high, which was lower still than those that started high and stayed high. So with high being a threshold of 400, which is very different than what the ADA and the AHA are saying, but still what they used for this study and seemed to actually differentiate quite well. So what's the take home from this? It does imply, again, that if we serially monitor these patients with cardiac markers, in this case NT-pro, it could be valuable for assessing and prognosticating outcomes. So how do we kind of, to summarize this, what is the utility of cardiac markers in CKM syndrome? Well, they've shown that both BNP, NT-pro, and troponins can prognosticate outcomes and progression to heart failure. The ideal thresholds for each have not been fully elucidated in the CKM population. Risk factors that warrant screening in diabetics and pre-diabetics are not known, although I think the A1C could be one that's helpful and available in all these patients. And then finally, the frequency of testing is unknown. So this is, again, where I think we as the lab can really step in and try to drive studies that do some of these with our cardiology partners and endocrine partners. So at that, I thank you for your time. Thank you for listening. And I think we have a few minutes for questions.
Yeah, well, that was a tour de force, Chris, across heart failure. And I think we're all becoming more aware of metabolic disease in our country, specifically here. And I think we all ourselves want tools. And I think this idea about that there's hidden risk under there that can be uncovered and the lab can be a leader there is really exciting, because we want to not just give patients bad news, but give them good news that you can take a different turn now, and you can prevent this, and the data are so strong.
Yeah, and it's an interesting paradigm shift, right? Because historically in most of medicine, we're using something to diagnose. We have a gold standard where we're saying, this is a biomarker for this thing.
Right.
But the paradigm shift now is that we're saying that the cardiac marker is actually a thing that's telling us before symptoms, maybe before echo.
And that's true, and that's why we think of cardiomyopathy, heart failure, that's a symptomology based. Mm-hmm. But having that structural disease there, or having that substrate that is going to develop structural disease and is at risk for that, we need those warning signs. Doctors, clinicians need tools to be able to help them inform patients, and patients deserve to know if there's something that's modifiable. We could keep talking.
We could keep talking.
I like the clinical lab mix that we have that you're bringing there, that lab taking the lead. As a clinician, I would appreciate that. But I think now let's have any questions.
Thank you.
While we're waiting, any more questions from that? I would say, what do you think the most exciting thing that you're seeing now around heart failure, diabetes, that's coming through your labs?
Oh, that's a good question. Most exciting thing around heart failure and diabetes.
Are you getting more traction with the clinicians there around this topic?
You know, I think that people are really interested. I think that for our endocrinologists, they haven't quite arrived there yet. So I think
Okay.
that's some of the discussions we've had is, should we be doing it? And I think the answer is yes. Then why aren't we doing it? And I think that I think especially because of emerging treatments, it's not always fully. I think they think that should be the first go-to over assessing for cardiovascular risk. I mean we know that those treatments are probably going to reduce the cardiovascular risk, right? But I don't know that we have a great understanding of the interplay between those two and what happens for particularly in substructure and structural disease that we're not seeing clinically yet.
I mean, the great news is that there's room for research there to move us forward.
Yes, of course. Yeah. Question.
So I have two questions. You can choose to answer both or one. The first one is, are there specific assays where you see the need for being able to measure lower volumes, and the value?
Lower concentrations?
Lower concentrations.
So there's specific assays, I think. I mean, I guess we don't know because we don't know. Speaking of just specific, well, we'll start with troponin. It would certainly be interesting to know. We have those thresholds, and we know that before we had a high-sense assay that we were missing information. If we could go lower, are we missing more information? If we could measure troponin in every human, what would that look like? And what's the additional risk stratification? Like if your troponin's less than 0.1 as opposed to 2, do you have better outcomes? So I think that would be interesting. I think NT-pro, we actually probably are missing some information there. So I imagine there's something physiologic to, it's a hormone, right? BNP is a hormone. So there's something that it's doing physiologically that's very important, natriuresis. So low BNP is probably pathologic, and I think that there's been some studies that have started to show that, but we don't have the assays that can measure down low enough at the moment, I don't think, that at least that are, because that's not how they're being used clinically for that risk stratification. So that's a great question.
Thank you. And then the other question was, what do you want to see from the diagnostics space that might open up doors for you to continue doing research?
Yeah, I think that's a good question. What do I want to see from the diagnostic space? I mean, I think certainly there are other biomarkers that would be useful in this context. I think that there's potentially a lot that could be done looking at continuous glucose monitoring and what's the interplay between that and A1C and the various cardiac markers that we have and renal markers, and how do those things all come together to provide us a holistic view of what's happening with that patient. Right now, it's kind of piecemealed when people order things and what that looks like. So I don't know if that's necessarily a request for diagnostics companies, but more about how we're thinking about disease in general. These patients are treated by their endocrinologist, and then they'll get referred to a cardiologist, and then they'll get referred and it's never a single unit. And it's not specific to cardiometabolic disease. It's just the topic of today's talk, but less of a siloed approach, including the lab in that, I think would be more important.
Great, thank you.
Well, Professor Farnsworth, Chris, thank you very much. If we don't have any more questions, I think we will wrap it up.
Lovely. Thank you so much. I'll be
Great.
after for
Appreciate it.
questions if anybody has any after. Thank you very much.